This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Long and Dr. Collier. Welcome.
Thank you.
So tonight we have an old doctor sitting here. We have some young doctors that are going to join us tonight and just talk about their lives as surgery residents. And let's see, I'll start with you, Dr. Long, just to chat a little bit. So you're a fifth-year surgery resident, is that right?
That's right.
Why don't you tell me what happens when you become a surgery resident? How did you elect to do this? What's your life like these days?
Well, when you make it to your fifth year, life gets a little easier, but 5 years of residency is long, and it's fun. You learn a lot, though. It's a big transition, and after you make the decision to go into surgery, then there's a whole new world after medical school that opens up, and lots more learning.
Was this a little shocking for you to actually become a surgery resident? I mean, you're sort of protected in a way as a medical student, are you not, from some of the shell fire and some of the...
There's definitely a transition that you have to make from a medical student to a resident, especially in surgery. I think there's a little more sick patients you have to deal with. You have to get comfortable with that. Yes.
Now we have with us also Dr. Collier. Welcome, Dr. Collier, and you're a surgery resident as well. Is that correct?
That's right. I'm a fourth-year resident.
And why don't you discuss your journey through life as to how this happened? And
sure.
How did you elect to do this, and what occurred?
Well, I went to the Medical College of Georgia as Dr. Long did. I was a physician assistant actually first, and worked for a surgeon in South Georgia.
Where did you work?
In Americus.
Oh, really? That's a nice town, yeah.
Yes, it is. It is. And I really enjoyed what I did, and the surgeon that I worked for kind of helped to encourage me to go back to school.
Really? Great.
I tried to figure out something other than surgery to do because I knew the lifestyle demands.
Well, what are the lifestyle demands? Does everybody know what it's like out there as they watch the show? What's it like to be
I don't know that you can appreciate it until you do it.
That's right.
That's what we tell even the medical students, that you can watch us even go through it, but I think the time that it takes to put into this, and even in practice, in surgical practice, until you do it, it's very hard to explain.
Now, you're a young lady, if I could say that. Have you encountered difficulties in doing this? Is it a tough thing to reconcile all the? It's a traditional male kind of bailiwick, is it not?
That's correct. I think a lot of that has changed over the course of the last 10 years. There's more women in medical school in general, and certainly in applying for a surgical residency. And so I haven't felt any different. I don't feel like I've been treated any differently during residency. I'm a mom, and so I think that obviously alters my lifestyle a little bit.
Now this is your chance to say hello to your child or children.
Yes,
you have some kids?
I do. I have a daughter, Lainey. She's 6.5.
Oh, yes? Well, you could probably say hello to Lainey out there. That's good. That's good.
Dr. Long's a dad.
Well, that's good, too. All right. Well,
I have a 15-month-old.
You have a 15-month-old. That's a nice story. And, this is, I think, such a tough thing to do. The surgery and in general, medicine, just the sacrifices are such a tremendous, it's very tough on any family to do this, isn't it? Very tough. And having time with your family and your child, it's a tough thing, isn't it?
It is.
Well, let's see. Now, along those lines, Dr. Long, you have an interest in pediatric surgery, is that right?
That's correct. I'm planning on moving to Nashville in June to start a pediatric surgery research fellowship at Vanderbilt University.
Yes. And then, so what will that entail exactly, doing that?
It's a position that I applied for through the National Institutes of Health for a research grant through an oncology arm for research into neuroblastoma. So tumor biology, cell signaling mechanism. Right. And so it's a 2-year position where I'll be in the lab with 3 main projects we applied for and got funding for. that I'll be doing my research in, and hopefully at the completion of those 2 years,
yes,
I will have some good stuff to show for it, and then I'll go on and finish my 2 years of actual pediatric surgery clinical
so
training.
that's a rather ambitious thing to do, is it not? And so you would specialize in looking after small children with different kinds of problems.
Absolutely.
And have you been interested in research? I mean, if you what did you major in college? Were you a
my major in college was biochemistry and molecular biology.
That sounds complicated, doesn't it? Yes.
So I've done research before, and I've been interested in research for a while, and decided that I wanted to pursue academic surgery.
Really?
And this is the next step in doing that.
So in doing that, it's necessary to write a lot of papers and sort of keep on the cutting edge of things. And it sounds like you're well in the direction of doing that. Well, let's see. And Dr. Collier, what are your ambitions as you finish your training? What do you want to do?
Well, I plan on just doing general surgery.
Yes.
I'm not going to do a fellowship. I'm going to move back to Americus.
Yes.
Actually practice with a surgeon that I worked for.
Great. What a nice story that is. That's a good story, isn't it?
Yes, sir.
And so in many ways, I think there's an interest in, I guess, smaller town healthcare.
That's right.
And it's really hard to get people to do what you're doing. Is that right?
It is. It is hard. And I think it's one thing to get people to come to the smaller towns to practice, but it's another thing to keep people in those small towns once they get there.
Yes.
And so we have several doctors in Americus who are young that are from that area that are now coming back.
So people come back, and I mean, I guess the joke is if you like to hunt and fish, that's a good thing.
And my husband does. So.
Oh, does he like to hunt and fish? So okay, well he's happy then.
That's right. He's happy.
He gets to do that. And is that your hometown? You're from that area?
I was born and raised there. My parents still live there.
Well, that's great. That's a good story. That'll be a good story. Well, as you've both been through a very taxing period here, what exactly is it like to be a surgery resident? I mean, the day starts with a nice breakfast, and you mosey down to the OR? Or how does the day start for you guys?
The life of a surgery resident is busy, and that's an understatement. And that's what I liked about it as a medical student, and that's what drew me. One of the things that drew me to surgery, other than operating, was that you never do the same thing twice. Your day's never the same.
Well, when do rounds start? I mean, when
rounds
you guys
usually start between 5 and 6 in the morning. You start rounding.
So a lot of people, just to hear that's a rather shocking thing, isn't it? Why do rounds start at such an early time, 5 to 6 in the morning?
There's usually a lot of patients on the service that have to be looked after. You got to get a plan for the patient for that day, because there may be a couple of things that need to happen that day. And so you got to get the patient seen that you're responsible for to get a plan. Then you sit down with your team.
Yes.
You run the list, is what we call it, to where you just review the patients together.
Yes.
And then usually that's around 7:15, and then we're breaking off because cases start at 7:30.
Yes. Now you mentioned a very important word, I think, and it's responsibility. So I mean that's the sine qua non of being a physician and being a surgeon. Is that your sense of personal obligation and responsibility to your patient? And I think the public needs to know that. When a doctor operates on you, there's a bonding that's just an unbelievable thing, isn't it? I mean, that's your patient, that's your responsibility. Everything that goes up and down, you have responsibility for, and that's what you're trained for. Is that right?
That's right.
Well, and so you start, you finish rounds and go over plans, and you have your more senior doctors are there giving you some knowledge, instructions, etc. about what to do. Now, you're a chief resident now, is that correct?
Yes, sir.
Now, what exactly does that mean when you're a chief resident? What does that title indicate?
In surgery, chief resident.
A lot of extra money? No.
Yeah, right. Yeah, right.
A lot of extra money.
But in surgery, chief resident's reserved for the residents in their final year, usually their 5th year.
Yes.
In other residencies, it may mean the person that's elected to be the chief in such as internal medicine. But in surgery, that's those chiefs that are the residents that are in their 5th year, and you're essentially responsible for kind of the day-to-day activities of the residency in terms of making the schedule, the administrative aspects of getting things together. If there's a visiting professor, for instance, and then you sort of help align the teams and make sure there's adequate coverage for the different services.
So there's a lot of leadership responsibility,
Absolutely.
Isn't it? And you're sort of a big brother, is that right, for the young, would you like to say that?
In a way, maybe, I don't know. It depends on, there's a hierarchy, I guess, but it's not a military hierarchy.
No, so the little guys are casual, you joke around a little bit, is that right?
Absolutely.
Yeah.
Yes, yes. And so, Dr. Collier, hearing these stories, you're going to be a chief resident next year, is that right?
That's right.
What sort of changes do you think that will have in your life as you become a chief resident? What is that? You have different tasks?
Well, it sounds like, yeah, as far as administrative responsibilities, there's a lot more to do. There's more paperwork, there's more meetings to go to, and certainly that extra responsibility of making sure that everyone below you is doing what
you have to do that. Right. And you began, as you do cases, I think maybe the way, it's kind of quite an art form, isn't it, as to how a younger surgeon gradually picks up the skills that enable the younger surgeon to be able to be totally responsible in an OR setting, which is it's a very dramatic place, isn't it? The OR, it's very dramatic. It is. And so you start out as a rather junior person, and you gradually get more and more responsibility, and you get to open and close or whatever. Is that what happens? Right. So people are watching you constantly.
That's usually how it goes. Is as an intern, you may not be in the OR as much as you want to be, but part of that's learning how to take care of the surgical patient, both before and after surgery. While you're in the OR, a lot of times you're just retracting and watching and
now, what does it mean when you're just retracting? What does that mean exactly? So maybe not everyone knows what that means.
To get exposure to wherever you're at in the body, the abdomen. For instance, then there's
you still pull the liver up these days.
You pull the liver up. You hold bowel out of the way. You hold a lot of different organs depending on where you're at in the abdomen, and so you may be retracting to watch, to learn as an intern. As you progress through, then you get to drive a little bit more, so to speak.
Right. Now, what exactly is an M&M conference? What is that?
So M&M stands for morbidity and mortality.
You guys have those?
We do.
You do.
Every week.
And that's a big deal, isn't it?
It's a very big deal.
And so it's important. Every bad outcome, every case that requires comment is discussed rather aggressively. And is that correct?
Correct.
And this is something that's part of the sort of the culture of the American medicine. The idea is that when doctors are constantly trying to do a better job, and everything that happens, every kind of unfortunate event is looked into with great rectitude to learn something from it. Isn't that correct?
That's correct.
Now, do you guys present the cases, or how does that work? How do you decide which cases to present?
Well, we all turn in what we consider to be our morbidities or poor outcomes, or our mortalities, or any deaths there are. And Dr. Long is actually the chief administrative resident now, so we give them to Dr. Long, and he can tell more about the process, but he ultimately talks to one of our attending physicians who goes through them and picks the ones that need to be presented. We discuss them with him, and then ultimately make a presentation.
So it's a big learning experience, and so you guys are used to you stand on your feet and you address the public. Now, one of the things that happens, I think, a lot of times is, I just asked this question. In patient interchanges, sometimes you have to deliver tragic news, or is there any special kind of, instruction of how you do that? Or is it just part of your human nature, the empathy that you feel for your patients about being able to give them some bad news sometimes?
There's no class, I think, that can prepare you for how to deliver bad news. Even though I know at the Medical College of Georgia we actually do have a class on how to talk about those issues. But going to a class and actually experiencing it yourself and being a part of it's two different things. And a lot of the way that I've learned, and I think a lot of residents learn, is by seeing those senior people above us, whether it's a senior resident when you're a junior resident, or even attending, deliver that kind of news, and you pick up the things, the nuances of how they do it, and that's sort of how you learn to do it.
I think that's one of the things about medicine, is the insight into the human condition. Really, it's the human suffering that we deal with every day. It's a tremendous honor and responsibility to look after people in those set of circumstances. So, I think it's great you guys are doing that. Do you have any comments, as you face the world, about the healthcare system is going through substantial changes? What do you think about that? Do you have any thoughts about some of or maybe you haven't had much chance to consider those issues? The way healthcare is being changed. Any thoughts? Any comments?
Well, you certainly cannot watch the news and not hear about Obamacare and You know, we do try to watch the news. We do get some
Well, occasionally.
Not very
You
often.
get to watch cartoons.
I was going to say,
when
I'm
you're a
watching
child.
Disney. That's
Thank
right.
God for DVR.
Is it Clifford the Big Red Dog?
Yeah, it's
no?
still on.
No, okay.
I watch a lot of Sid the Science Kid
Okay,
with my
Sid,
daughter.
yes.
But no, you hear about Obamacare and you hear the things coming down, and a lot of the aspects that are talked about do not sound very promising
yes.
for the continued delivery of health care. It certainly does not seem like it's going to be as efficient as we would hope.
You know, one of the things that I think it could be talked about a little bit is the culture that you guys represent. I mean, there's sort of this culture. It's a very traditional kind of viewpoint. The physicians, the advocate for the patient with his responsibilities that have, the idea of always learning and trying to do a better job, and it's and tremendous sacrifices that physicians make, particularly young surgeons such as yourself. Big sacrifice, big deal. And I think the American people have to be cautious that there's some kind of arbitrary decision making from centralized decision making may impact on a lot of the good things that exist in the American healthcare system. And you know, I think another issue I might bring up is that you guys mentioned you're so involved in what you do. Mm-hmm. It's very difficult to understand what might be hatched out. I mean, what might be hatching out. Mm-hmm. I mean, everyone is just enmeshed in their day-to-day activities, and in some ways, we're a little powerless about the whole system. Isn't that correct? You guys don't march with signs, right? You're busy looking after patients.
At this point, I think it's safe to say you're not doing general surgery or surgery just in general if it's not something you're passionate about. You certainly don't go into this to make money, because this is a large sacrifice.
That's correct,
to do it. So you have to be passionate about it and really want to do it. That being said, you worry about losing that attraction to the younger generations that haven't applied for medical school yet, or that may be getting into medical school, to ask them to make that sacrifice in the future, knowing that they may not have that autonomy.
And I think the other thing that's out there is that the government may arbitrarily injure your patients in some unintended way. I mean, that's an issue about whatever regulations are put in there. It's complicated, isn't it? The care of patients needs to be particularized. I mean, would you agree with that? I mean, each patient, it's very difficult to understand the right thing to do with these patients. Do you agree with that? Is that a fair statement?
Not every patient fits into an algorithm.
No, it's very complicated. All these different factors that require a substantial judgment. Well, have you guys had amusing experiences in your travels thus far? Any that you dare talk about? No.
I've had all kinds of amusing experiences.
Maybe you'd rather not talk about it. I don't know.
How can I talk about and not break HIPAA?
Probably not. No, it's lots of you really have all the I guess the human comedy, the tragedy, and certainly you participate in that. Is that
it's hard
correct?
work, but we have fun. I mean, there's 20 of us in the residency.
Yeah, that's a pretty big number. How many? The numbers have expanded, haven't they?
We have 4 per year.
Mm-hmm. Yes.
It was 3. How many years ago now?
It was 3 there was about 4 or 5 years where there was 3, and prior to that there was 2. So we've expanded to 4.
What kind of tests do you guys have to take as you go through? And maybe you can discuss finally becoming a board certified surgeon. What do you have to do, and how are you being tested?
Well, every year, every general surgery resident across the country, every year usually the last Saturday of January, has to sit for something called the ABSITE, ABSITE.
Yes.
Which is a standardized test over not only basic surgical knowledge in the basic sciences, but basic and clinical science.
Yes.
How to operate, operative decision making. And you're compared to your year. So all the 5th years are compared to each other. All the 4th years are compared based on their score. So that's every year. And then once you're done with your 5 years of training, you become board eligible.
What exactly does that mean?
That means that if you have met the requirements as set forth by the American Board of Surgery during your residency for the 5 years, then you can take the first part of your board, which is a written test called the qualifying exam, which is what I will hopefully take in August. I finish in June, and then in August I'll take the qualifying exam. It's a written test.
Yes.
If you pass the qualifying exam, then you qualify for the second half, which is the certifying exam, which is an oral exam.
Yes.
And that's months later.
And then, is that finished for you? I mean, that's the, or do they have some more little hurdles to jump over?
Well, once you pass that, you're good for 10 years, but you have to do maintenance and certification.
So you have to have another, and the other thing is, during this period, it's necessary to take a substantial amount of classes, continuing educations, go to meetings. You just can't live in isolation.
That's right.
And so that's a rather daunting thing to do, isn't it?
It is.
And it's important to make an okay grade on these tests. Is that right? I mean, you attract some attention if you have a poor score.
Yeah, I would say so. Yeah, you don't want to do poorly.
Yes, and so there's studying involved with all the other, now, what is the 80-hour work week rule? What exactly is that? You're not supposed to work?
Sure. Well, there's supposed to be a maximum number of hours that we can work, which is 80.
Does that include, could you then study in the remaining, is that legal? Is it legal to study in the other time that you have?
It is legal
you
to
can
study.
still study,
So
all right.
Yes,
so it's
you have
80,
to go home and study after
so it's
that.
80 hours of work, plus,
Right. Time you're in the hospital.
plus you're expected to study and do work,
That's
intellectual
exactly
work, right?
That's exactly
and then
right.
the old surgeons like myself just
Yes.
say, you guys have it it's such a soft thing,
That's right.
but it's still a pretty daunting thing.
It's still pretty tough, but we have conferences every once a week on Tuesday evenings where we discuss a topic, be it the stomach or the liver, some topic to help us prepare that our department helps us with.
Yes.
We have a faculty that will help teach us that. So that helps some with our studying, but it's mostly on our own.
Right.
That's correct.
And let's see, do you have visiting professors that come and lecturers?
Absolutely. Absolutely.
Now you have meetings. You go to meetings, or what about that? You have national meetings you attend, or you present papers.
That's right. It's in our department. As a fifth year, you're expected, or it's your privilege to go to the American College of Surgeons annual meeting, the clinical congress.
Yes. And
so,
is that in the beautiful town of Chicago?
I think it will be this year.
I get to go to Chicago this
past
year.
year.
Chicago, yes.
Myself.
It's probably in
my
February or
chief class.
something they have it.
No, it's in October.
October.
It's October. So
That's not
my
too
chief
bad.
class
That's not
went
too
to the
bad.
meeting in
That's not too
San
bad.
Francisco this year.
So it'd be all right.
It
So
was nice.
they pick like beautiful, subtropical places for these meetings.
No, I think they rotate between San Francisco, Chicago, and Washington D.C.
Okay, all right.
But then if you submit research or for a presentation, a poster, a paper that you've done to another meeting, then you get to go to that meeting.
Now, have you presented some papers and maybe won some awards in your travels through the world?
I've presented at a couple of meetings. The Southeastern Surgical Congress I've presented posters at, which is just a collection of surgical societies from the Southeast.
Right, yes.
And then I've presented some basic science research for the American College of Surgeons Committee on Trauma competition, and I won the state of Georgia for basic science for 2 years.
Now this is that's in addition to your 80 hours a week, which we all complain about. You're not working enough, and studying, and then doing this research. That's very. Plus, you've got your family issues there. That's a lot, isn't it?
It's a lot.
So it's
It
a
gets
lot.
busy.
Do you have a chance to sleep, or is that, do you guys still sleep, or is that stuff?
We squeeze some sleep in.
It's pretty tough on that.
It is.
Well, why don't you just give us a little vignette about some of your research? What about a 30-second thing about some of the stuff you might have made observations about?
The basic science research that I've been a part of in the lab of Dr. J.B. Wong at the Mercer University has focused on the cell signaling mechanisms involved in endothelial cell permeability.
Yes.
And looking at what regulates leaky capillaries in states of shock.
Now, why is that important? The little capillaries, they keep the blood cells, they keep everything in there. If they leak, that's real bad. What happens if they leak?
A lot of physiological conditions that give physicians fits in the ICU and even in trauma is, for instance, the lungs when they fill up with fluid during shock, or if somebody's going into acute respiratory distress syndrome, and how do we mobilize that fluid away from where it doesn't need to be and get better oxygenation across those membranes. And the capillaries become leaky, allowing the fluid to leak out, and so we've looked at sort of on a molecular level what regulates that and maybe targets for therapeutic intervention.
So that would it would help the so-called shock lung.
It could help pulmonary edema, acute respiratory distress syndrome, and people who are ventilator dependent because of this fluid overload. And
we could get into a little discussion. I don't know if this is the right venue for that. We could discuss the brain's role in this, but that's probably for another time. But these capillaries are very fascinating and interesting. I mean, the ones in the brain where we have the blood-brain barrier are just some of the most complicated pieces of anatomy that exist. They're exquisitely regulated, and it requires lots of attention to keep the central nervous system the way it should be, and the same in other places. So good. Well, that's a good. That seems to be a good thing to do. And at Vanderbilt, you're going to be working in what exactly project do you have in mind? You mentioned, I think, neuroblastomas. Is that right?
Correct. It's going to be the lab that's there is already a very well-established, nationally known lab that researches neuroblastoma under Dr. Dae Chung, the director of pediatric surgery there. And I'm going to be joining on a couple of projects that are already ongoing and taking a different direction with a few of these projects we've discussed, which is what we applied to the NIH for.
Right. Now, is there in looking at the human genome, are you parsing out some of the genetic issues that may be involved in the neuroblastomas?
One of the projects that I'll be a part of is going to be comparing the stem cells within neuroblastoma tumors to normal non-tumorigenic stem cells and getting a genetic profile to compare any differences in how these stem cells are regulated or deregulated compared to a non-effective.
Okay, so we have a rather general audience out there. You have 15 seconds to say what a stem cell is.
So a stem cell is essentially the cells that make us up as we're beginning to form, from the embryological point.
Yes.
And these cells have not been told what they're going to be yet.
Right.
This cell, it can become any cell in the body.
Right.
And so they're obviously, if you listen to the news, a hot topic in the news for interventions in certain diseases. But they're cells that can become anything.
Right. So, Dr. Collier, I mean, in your travels, we have stem cell issues in the You're familiar with what your destiny will be in Americas, is that right?
That's
There's a new hospital there. How big is the hospital?
It's 76 beds.
Yes.
Several operating rooms.
Yes.
They have a big complex.
This is a new hospital.
Brand new. It just opened in December, actually.
Yes.
So it's up and running. The surgeons are operating there now.
Yes.
So it's very nice.
And how about managing trauma? Is that going to happen or not happen there?
Well, I don't know that we're not necessarily associated with the trauma service now. It is a small area, but we do get some traumas initially. Certainly, I hope to, after my training here, be able to stabilize what I would need to stabilize in order to then maybe let them be transferred to a level 1 center.
And so, what sort of cases do you expect to be doing? I mean, you're familiar with that part of the world. What sort of cases would you be doing in that environment, do you think?
Well, there's a lot of bread and butter, so to speak, cases. So, inguinal hernias, a lot of breast surgery, colon surgery, thyroid surgery.
Yes. So it's really important, I think, for the whole Sumter County to keep that hospital in good stead. And I hope people realize that. Is the American healthcare system requires lots of it. It's very complicated, and there are all kinds of different components to it. And so we have like a lot of research. There are people that are looking after citizens that live in rural areas. There are lots of things that are involved in that. Well, let's say we have about a minute left. So do you have any comments about where you expect to be in 5 years? Any thoughts?
In 5 years, I'd like to be in Georgia or Tennessee, where my family's. Mine and my wife's family are between Georgia and Tennessee, so somewhere around there, operating as much as I can in pediatric surgery and able to continue some of this research that I'm interested in, and kind of use this as a springboard to go forward.
And for you, Dr. Collier?
Again, I hope to still be in Americas at that time if they'll keep me, enjoying time with my family and old friends.
Well, it's been great having you young doctors here. I know that as I sail off into the sunset, the profession is going to be in good hands. So thank you so much. Look forward to seeing and hearing some good things about you and your career.
Thank you for having
so
us.
much. Thank you.
Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national and international basis.